Hi everyone, today I'm here with Dr. Centric, a otolaryngology head and neck surgeon.
Yep.
Okay, so it's kind of confusing, but thank you first of all, Dr. Centric, for being with us today.
My pleasure.
And so could you briefly describe what otolaryngology or ENT is and the head and neck surgery aspect of it too?
Absolutely. So ENT focuses on medical and surgical disorders of the ears, nose, throat, and basically anything above the clavicles except eyes and brains.
Mm-hmm.
We try to stay away from those unless they're supposed to be there, which is kind of rare.
Mm-hmm.
I chose ENT because it gives a really nice mix of clinical medicine in the office and surgical procedures you can do to kind of help your patients in extra ways. But a lot of my day as a general ENT focuses on kind of more common things. I see a lot of kids, mostly for ear issues, simple stuff like that might require ear tubes, and tonsil issues and snoring and things like that. I see a lot of adults for issues that include chronic sore throats, a lot of which end up being acid reflux, a lot of allergy and sinus disorders, ear problems, and then other generalized issues in the head and neck. And a lot of the surgical portion focuses on a really broad stretch of things. So an average surgery day for me might include fixing a hole in somebody's eardrum, and then maybe moving on to a sinus operation, and then moving on and taking out a thyroid gland. So it's very, very diverse. And there are some crossovers between ENT and other specialties. For instance, endocrine surgery. A general surgeon might take out thyroids and other glands up here. We take out thyroids and other glands up here. But by and large, there's a lot of ENT that's really stuck up here. So we're the only people that do most of what we do, which is very nice because it gives us a nice niche to work in where we can really focus in on specialized problems for our patients.
What time do you usually come in and what time do you usually leave, and what kind of, does that vary from day to day?
Yes, absolutely. One of the nice things about the environment that I work in is the organization allows us to be very flexible about our schedules and actually encourages us to have kind of alternative hours, like earlier hours or later hours to accommodate people with jobs. So usually I come in anywhere between 7 and 8, depending on the day, and I'm almost always home by 4 or 5, depending on what happens during the day. And that's a lot of my design and my choice. If I wanted to, I could certainly work 6 to 6 every day and probably more than that. But I find it very healthy to kind of strike a work-life balance, and it's 8 to 5, 7 to 4, something of that nature. There are long days where I have a lot of surgeries and I won't get home until 6 or 7, and sometimes I get lucky and I take a short day, like today I'm leaving at noon because I need to.
Would you say that ENT is very conducive to a work-life balance and also maybe scheduling flexibility so that you could do like administrative work or mentoring or other things like that?
You know what? I know there's a lot of stereotypes around certain specialties having more of a work-life balance and not, and I think a lot of that relies on the person and also the work environment. So if you want to, in any specialty, you can run yourself into the ground. You can spend all day, every day at a hospital or in an office and really, really go for it. I think that ENT is a specialty that allows you to strike a better work-life balance, but also where I work allows us to strike a better work-life balance because we know that it's very important to be healthy as a physician in order to provide better care for your patients. So, but yeah, ENT is classically one of those things where you can say, yeah, I have a pretty good work-life balance.
So it seems like most specialties are moving towards like bigger groups and things like that. I'm not sure if this is part of a bigger group or... and would you say that bigger groups allow you to do that more, or like if you're like an independent, I'm not sure if they're independent solo ENTs?
Yeah, again, that really depends. So I trained in Philadelphia, and almost everybody I worked with was private practice, or kind of loosely affiliated with an academic center, and then we had one larger group that was like absorbed and just integral with the university, and the way that they ran their lives was just completely different. And out here in Northern California, this is the land of large health systems. There are several big name large health systems in the Sacramento area, and there's very few honest to God independent physicians left that have hung up a shingle and are running their own practice. So even if somebody has their own practice, oftentimes they're sort of contracted on the back with one of the larger systems to provide like EHR support or billing support or something like that to help reduce their overhead. And that's just the practice climate in Northern California. So out here, there are very few ENTs that are independent. And those that are, I'm sure they're doing fine, but there's mainly large groups and one very large private group. But they have, a lot of collective bargaining power because they've been here forever and it's a large ENT group. I have a friend that works in rural Oklahoma, and he and I trained together, and he went right back home and, put his name up on the wall and bought an office and opened a practice, and he is completely thriving, but he's the only game in town. It works really well for him there. In that environment. So it really depends on where you're going to go. But you're right, in general, there has been a trend over the last probably 15 years or so, a lot of specialties kind of consolidating into a larger health system. And you see that with primary care too.
What's the most challenging and rewarding aspects of ENT?
There are always those patients in those cases that can be very challenging, either from a diagnostic standpoint, like what is going on here, challenging procedures, surgeries, there's always technical challenges there. And sometimes it's challenging to deal with its strong personality of a patient where you think that there's something going on and they're just having a little bit of difficulty like getting people on the same page. So I'd say that probably working on very challenging diagnostic things is the most, because it really keeps your mind pushed as to like, you can't get complacent and doing the same things all day, because you might be working through your whole day and say the same things 10 times and see the certain things that are just very common, and then out of the blue, wham, you'll get something really weird. And you just have to stop and go, give me just 1 second and sort of dig back to first year medical school and think about that thing that you think you heard of that you can't quite remember, and maybe step out and jump on UpToDate for a second and be like, what is that? Or reach out to a colleague or talk to somebody to figure out what in the heck you're doing, and then bring it all back together to try and help that person. And the most rewarding, honestly, comes from patients. When somebody comes back and they feel better and they're doing better and they look better and they say thank you. It's really nice to hear and it's really nice to see. And it sort of helps me kind of tuck that aside so that if I do have a really challenging patient, I'm like, you know what, overall we're doing great. We're going to do the best for every patient, but it's nice to be able to actually help people and see that improvement and change.
And are there certain personality types that do best in ENT?
Oh gosh, I'm sure somebody's done research on this. I'm sure there's a Myers-Briggs that fits the best, but my experience with it has always been that ENTs in general are usually pretty laid back, usually pretty nice. There's always exceptions to that, and training on the East Coast I'm from the West Coast, that's why I'm back here. I was like, oh, get me out of here as soon as I was done with training. But there's a Northeast mentality that's a little bit more aggressive and sort of like, I don't know, angry in a certain way. I love my East Coast friends, but by and large, ENT is usually one of the more relaxed specialties. We're usually super easy to deal with. Pretty happy to handle almost anything in our wheelhouse. So, and my partners here really chill, super relaxed. It's a good environment to work in.
Okay, and since ENT seems to be a pretty competitive specialty, what tips would you give medical students to match into? ENT is it a subspecialty of general surgery, or
no? It's its
own thing.
Yeah.
Okay, how would you recommend we match into that, or do things to match into that?
So let's see. I graduated from medical school in 2009. It's 2018 now, so my residency was 2010 to 14. So you're getting old advice, but. I know when I was going through, and then even in residency when I was interviewing students and things like that, board scores were very important. I know that's a total cliche, but it was one of the specialties where board scores are very important to kind of get your application to the top of the pile. But above and beyond that, as both an interviewer while I was in residency and a previous interviewee, I think personality has a lot to do with it. You want somebody who is intelligent, obviously. You made it to medical school, you've got intelligence to some degree, but somebody who knows their stuff, and that's always very important. Somebody who's interested in the field. There's actually a ton of ENT history that's fascinating, and most ENTs would be happy to sit down and probably walk you through some esoteric story about some doctor they knew whose name is on some device or whatever, because there's all kinds of stuff like that. But I think you end up becoming really interested and passionate about the specialty because it's so unique amongst medicine and so focused. So definitely a drive and an interest. Most programs want to see a lot of research, ENT research. General research is fine, but most want to see some interest in ENT research. And then, as with many things, many academic programs want to see somebody that wants to be academic, whether or not that's a reality or not. But again, personality is important. I know when we were interviewing residents for our program, we'd look at somebody and go, can I work with this person? When you've got 20 people that look great on paper, and somebody rotates through and you think, I could work with that person and that person, this one, maybe not for us. That's really important. So I know ENT had unfilled spots, I think, last year and the year before for one of the first times. So the academy is like all in an uproar, like, did we make it too competitive? So there's actually like articles published in our journals about like, what are we going to do about this? So that might be a good time.
So I noticed you're an osteopathic physician. I was wondering, since ENT is so competitive, did you find it more challenging, or do you think it's more challenging coming from the osteopathic side? And also, kind of on a related term, do you use like OMM with your patients?
Personally, I don't. I do have a couple of friends who are in ENT that do, but I think more commonly people probably don't. And whether that's a good thing or bad is a totally different discussion. Is it more difficult to come into ENT as a DO? I think so, absolutely. Especially on the West Coast, there was a bit of DO bias in the ENT programs that I rotated with out here, trying to kind of like get my foot in the door. My board scores were awesome. I took the USMLE. I think they were anyway, I don't know. And I had everything on paper and got really positive feedback, some rotations out here, but was actually told, point blank, we don't take DOs. And I was like, thanks. So the program that I ended up with in Philadelphia was actually one of the DO programs. And the interesting part about being in Philadelphia was that there were 4 ENT residencies in the metropolitan area. And so we had a lot of interaction with the other ENT programs and the other ENT residents and hospitals and facilities and things. And I think that by and large we all had very comparable training. So the program that I ended up through, I thought was fantastic. But it did, I had to go all the way to Philadelphia to do this, but it was the best program for me. It was excellent training, and I think that it was very much parallel with any program in the country. But yeah, it was a couple of extra steps for sure.
And do you think that's still the case, or because like I heard they're merging the residency programs and things in 2020? Or
there's a lot happening with that. So the program that I went to in Philadelphia did get dual accreditation through ACGME, and they got we started that process when I was there, and it was actually granted this year, which was a big deal. So that's great for them. It sort of gives them a lot of survivorship there, and the ability to keep taking osteopathic students if they choose to. But what it means is that they can stand on their own, which is great for them. And I don't know that ENT actually is merging. I know a few of the specialties, I think, opted to maintain an independent academy, and I believe ENT was one of them. So the programs that are the strongest amongst the osteopathic community, like the one that I came from, are now getting that dual accreditation so that they can stand on both sides of the line, regardless of what happens. So lots of change on the horizon and all, but yeah, I know that some of the osteopathic programs have stepped up to that dual accreditation.
How has medicine changed since you started practicing, and what future changes do you see in the horizon?
Sounds a change. There's so much more to do with the computer. When I was in residency, and I mean, I'm not that old, but when I started internship and residency in 2009, I think one of our hospitals was on an EMR system, and of all the hospitals we covered, I think I've been through 5 or 6 EHR transitions through residency, just going from paper to computer. So that was super painful to go through every time. So that's been one of my biggest observations, is the change in the way that health information and workflow happens. So I think that transition into information availability is huge, is a big difference. What I've noticed since starting with my current organization is that the availability of information is boundless. The systems that we use are integrated with almost everybody in Northern California, and there's a huge network in this particular EHR across the country. So I can pull records from somebody in North Carolina like that without worrying about it. And I can see clinic and chart notes from anybody in Northern California. So it makes it so much easier to manage a patient that may come in and you say, well, what can I do for you? And they're like, So you can kind of dig around a little bit. It doesn't take long at all, and find out why they were sent here, who sent them, what's been done, to see that maybe they've been seen for the same thing 10 years ago at Stanford. You're like, oh, I see that you had this 10 years ago. So that's been excellent. And I think that's actually a good push towards like elimination of redundancies and cost reductions overall. But since I started, I've also seen a lot more focus on quality outcomes. And I think of the word quality as a positive thing, but when you get into practice, it may not actually turn out to be a positive word at all, because some of the ways that these programs coming down the pipeline from Medicare and Medicaid services and things like that are designed are not the most realistic, in my opinion. And so when we're told, hey, this is a quality measure, and you look at it and you're like, nothing to do with the way I practice medicine. I don't quite understand that. Why am I being judged on it? Sometimes it takes a little bit to kind of integrate that into your day and figure out what to do with it. But again, there's a strength in numbers idea there, that when you have a large health system, there's people and consultants and physicians within the group that are responsible for managing all of that information and disseminating it down, and then coming to you and saying, here's what I need you to do. And a lot of times it's much more simple than kind of looking at this huge federal report and trying to figure out how to not get money taken away from you.
How well are ENT physicians compensated generally, and how would you recommend maximizing kind of that flow?
So I think ENT in general, community ENT in particular, outside of a major academic center, is very high volume, and that sets it apart from a lot of other specialties. Here I see about 30 people a day, and that's pretty typical for my day, and it's fine. I'm still within those hours we talked about earlier. I'm in and out, and charting's efficient, and that's a lot because of what I've done with it, but also because it's just the way ENT flows. It's very heavily procedural. So we do a lot of procedures here in the office, as well as surgeries in the surgery center in the hospital. And that allows for more, I guess, billable items, if you want to put it that way and think about it that way. But I think as a whole, ENT is very well compensated. Okay. And again, this is a practice model thing. The way that we're reimbursed here is very different from the folks that I worked with in Philadelphia. And of course, I keep in touch with a lot of people and talk about reimbursement models with my residency friends and stuff. And a lot of them are in systems very similar to the one that we're in here. But by and large, it's very comfortable and lets me do what I want to do, which is come to work, see a lot of patients in a really efficient manner, help a lot of people, and then go home and relax.
Okay, so what tips would you give us to become good doctors?
Listen to your patients. Absolutely listen to your patients. That's number one. I was at some seminar a few months ago about patient experience and how patients experience their medical care and things like that. And one of the points that was put out right up front was that I think an average physician, and I don't recall where this number came from, but an average physician gave a patient something like 17 seconds to talk before cutting them off. And sometimes that's really hard to do, because you can look at what the nurse gives you when they put a patient in the room, or within 2 seconds of looking at them, talking to them, you're like, all right, I know what's wrong with you. Can we go now? Let's go. Because we're trained to be so like vignette, answer. And you're like, I know, pick me. But you have to let them tell you. And a lot of times when you just listen, not only do they tell you exactly what's wrong with them, half the time they already know how to fix it. You just need to kind of like nudge them in that direction to come to their own realization. And people really appreciate it when you listen. Really appreciate it. It doesn't mean you have to spend 45 minutes like you will as a third-year student in the room getting absolutely no useful information. And that's fine. You'll get there. But especially when you're out on your own, listen to the patients. They will tell you what's wrong with them, and it will make your life so much easier in the long run, and they will be so much happier with the care that you're delivering.
Great, so make sure you're listening.
Yeah.
Well, thank you, Dr. Centric, for being part of this interview, and thank you guys for watching. If you have any questions for Dr. Centric, leave them in the comments below, and I'll ask them and relay the answer back to you guys. Thank you guys for watching, and have a great rest of your day.